Good morning, ladies and gentlemen, and welcome to this Cabinet decision meeting for health and social care. It's Wednesday the 15th of November and this meeting is starting at 10 a.m. In the Executive Room, 3rd floor of Portsmouth Guildhall. The first item on the agenda are apologies for absence, and I have an apology from Councillor Luke Stubbs, who is the Cabinet Member for Adult and Social Care. For those of you who aren't aware, my name is Donna Jones and I'm the leader of the Council and I'm sitting in for Councillor Stubbs. The reason being is that I was invited to meet with the Secretary of State for Health this morning, Jeremy Hunt, and Councillor Stubbs has gone to that meeting on my behalf as he is far more knowledgeable about all items relating to winter shelter and health and social care than I am, being the Cabinet Member. Joanne, any other apologies for absence? No. Okay, thank you very much. Item 2, declarations of interest. I have had a good look through the agenda, I've read the reports and I can confirm that I have no declarations of interest. We also have Councillor Vernon Jackson here.
Hello, also no declarations of interest.
Wonderful, thank you very much. Okay, so we're going to start with item 4 on the agenda, which is the Adult Social Care Intervention and the Measures Update. And we have Dave Adams here, who is our lead interventionist, to introduce the report. Dave.
Thank you, Leader. Good morning. If it's helpful, I can summarise the content of the report and then take any questions. So the decision was taken to conduct an intervention back in autumn of 2015. That was largely arising from concerns that we had at the time that clients were waiting too long for a service, and with growing financial pressures it was unlikely that we were going to have the opportunity to have more resources to alleviate that, and so it was a question of what could we do to make the work better. So we conducted an intervention that comprises 3 stages. The first stage is a check or a study phase, which was conducted from October 2015 to December 2015. That revealed that our processes at the time were overly bureaucratic and labour intensive, and that was in some ways getting in the way of social workers and occupational therapists delivering on what mattered to clients. So after that we began a redesign phase in the spring of 2016, and that's an experimental process whereby you take live cases, real cases, but outside of the existing operational process, but within the law, and experiment with what can be done to make it work faster and better for the client, and obviously as you're going, measuring the efficacy of those processes. That was successful in us learning that we could indeed provide assessment processes much more quickly and effectively without some of the bureaucracy in the existing system, and so a decision was taken in the summer of 2016 to implement that in full and scale it up across the wider system. Since then it's been a long process of implementation because it's quite unusual in terms of the way that you implement change. Each individual social worker and occupational therapist is trained on their own one-to-one with an interventionist or a member of the intervention team, and that training is bespoke to them and takes as long as is necessary until they're confident and comfortable with the new process. So in a traditional model perhaps you'd have maybe a few days of training or a week, and you'd train large groups of people quickly to get things done quickly. In this approach it's literally as long as it takes. So it took until the spring of this year for every single member of staff to be fully trained in the new process. Now, in terms of the content of this report, I was asked to provide this by Councillor Stubbs to basically kind of take stock on where we've got to in terms of that. As part of an intervention, one of the other things you do is introduce a whole new suite of measures to measure as far as possible from the customer's perspective. Quite often in health and social care systems across the whole country, people ask for help or contact services, but it's only when a formal referral was made that the clock starts ticking, as it were, and those services measure how long the process is taking. Whereas what we wanted was a system whereby the moment that someone phones social care and says, I need some form of help, that we start the clock there and then measure in days how long it takes each part of the process to play out. So in terms of then the performance, there's a series of charts in the report setting out how long it takes in days for us to deal with demands and then assess the need and then meet the need both for community social work and community occupational therapy. It's important to say that these charts may look unusual compared to what you're used to receiving. It's because of the method we use of statistical process control. What it's designed to do is show variation. So while we can say quite clearly that averages have improved, there's still a huge amount of variation between individual cases due to their complexity or due to ongoing issues in the service. So although, yes, we can say we've cut 8 weeks off of the time to assess people for social work and several weeks for occupational therapy, there are still cases that are taking too long, and part of this is in terms of trying to improve continuously. Every time we have a case that takes longer than we expect or longer than the norm, we get managers then to investigate what happened in that particular case, what were the blockages and barriers, and then importantly, are those blockages and barriers systemic, i.e. will they reoccur, and what can we do to remove them? And in that way, you get a sort of organic improvement process that will continue over time. So that covers off the community social work and occupational therapy. We've also provided data on the demand in terms of calls into the social care help desk, and this remains entirely flat over the last 2 years, although there's variation day to day. The average has not changed as a result of all this work, but what has changed is the number of calls we missed. So we're getting better at answering the phone on the social care help desk, largely because we've removed lots of the administrative work that staff are having to do, and so they've got more time to answer calls. Just to conclude, there's a series of challenges that we still face in terms of getting this done. The scope that we had originally looked largely at the core of the assessment process, i.e. a client asks for help, they're assessed, a support plan is prepared, and then care is sourced. Now, we've done a lot of work to make that whole process more effective and more efficient. What we haven't done yet is look at the actual service that the client receives at the end of it. PCC commissions a lot of different care services in the city, and those have not been addressed under this approach, and we, in order to improve those in the future, we'll need to do work in that area. We're having trouble, like a lot of authorities around the country, in terms of sourcing care quickly, and that will continue to constrain our ability to meet need quickly unless we address that. So that'll be one of the things we're looking to do next year. Our second key challenge is in terms of management. My own role as an interventionist is to go into a service and work with them for a period of time, and then equip the managers to do this work on an ongoing basis so that the service maintains the improvement. It's very difficult for particularly managers. For staff, it's much easier. They're just trained in a new process. Whereas for managers, it's a complete change in perspective on the way they're used to managing the service. And that's proven difficult to date and will continue to prove difficult until we crack it. And the third key challenge is IT. When we did the original study of the system, we found that the existing IT is not fit for purpose. The service is in the process of procuring a new IT system, which appears to be more suitable for our needs and more flexible, but it's vital that that's configured properly. So that's how we got there, where we are now, and the key challenges. I should also say, whilst this progress is encouraging, it's only part of a journey. We want to get to the position where we're not talking about how long does it take to do these things, because ultimately the best service we can provide will be one where a client contacts the service, asks for help, and we say, when would you like us to see you? And we know that that can be done. We also know that's actually the least resource-intensive way of doing it, but it's just difficult to get there. But we're confident that we will. Thank you.
Thank you very much, Dave. Gerald, any comments or questions?
I think a fair number, if that's all right, David. It's a very interesting report, and it's good to see that work has been done that means that it takes less time to do an assessment. But actually, when people are contacting social services, they're after a service. So could you talk a bit more about how this has improved people receiving a service? Because that's the judgment of whether this works or not. And particularly, it would be, I think, useful to see how this works in reducing bed blocking at QA over the winter period, because we know that's the difficult time, and we know we have significant feedback from the hospital that they can't get people out of beds at QA because Portsmouth City Council can't procure services to support people either in their own home or in an alternative place. So could you talk a bit about what progress you've made in achieving those as a starter?
Before he does, which are good points, I just want to add something on to that, because actually, just to set the context as well from the sort of leadership of the council. In sort of 2014, we took stock of where we were, and a lot of the waiting times for assessment of care packages, particularly in our largest department in Portsmouth City Council, adult social care, we have over 850 staff that work in that one department, and also obviously public health being part of the solution of a number of these things as well. But adult social care, that the waiting times were not where we wanted them to be. In addition to that, 4 years into an austerity programme, we also knew we needed to save money, but actually improve the service. So that's why we took a decision, the Conservative administration, to set up a £500,000 pot to support systems thinking through the Vanguard method throughout the council, and particularly in adult social care. So for an example, we live in in local government. Councils, as you know very well, Gerald, are in a reactive situation to the government, the legislators, the main decision makers, and those that hold the purse strings. Now, when you look at the way that adult social care protocol, procedures, legislation, governance has grown and changed over the last 15, 20 years, we started off with a process of someone gets referred, you have to do something within 20 days, 30 days, whatever. They then have to have this check, they have to have an occupational therapy, they have to have this, they have to have that, you have to get a letter from the GP, and all of these processes. That was 20 years ago. Then legislators and a new parliament changed some of the rules around funding, and it's not called, a particular type of disability grant. It's now called something different, and that brought with it a new procedure. So now we have the original 6 procedures, and we built in another couple because of a change. We didn't take out the ones that we didn't need. We just added a couple on. And throughout multiple changes in legislation, through the governments changing or learning and improving and driving things forward over the last 15, 20 years, we ended up, particularly in learning disabilities, which is the one that I'm going to ask Dave to focus on in answer to your question in a moment, with a process that I think had something, Dave, like 30 different steps in it, or 40 steps in it, from someone being initially referred for a learning disabilities package. It could be a young person, 22, 23 years of age, Down syndrome, or severely mentally and physically disabled. And actually, what we've done is, very scientifically, through the systems thinking, is gone and looked at, with the current legislation, what of those processes do we actually need to do legally? What do we want to do ourselves to govern public money and risks and checks and balances? And we were able to take out a whole load of things, processes, from someone's file being referred from me to you to someone else, and it goes all around the houses and comes back originally to the social worker who started the whole process off, who then gets, in some cases, 15 months later, a decision that they can now start approving a care package. And that is appalling. And the number of days that people were waiting for care packages, and I'm using LD, learning disabilities, as the example here, was really poor. And we've done a brilliant intervention. We've managed to reduce the time. Dave will give you what it was and what it is now, and what the standard is that we are hoping to achieve as a city council in that particular area. We're not quite where we want to be, but we are within batting distance now. And that is a really good example, in answer to your first question, Gerald, of how systems thinking has improved the service care packages for people. With regards to the hospital, and the discharge point that you made, actually QA Hospital in Portsmouth has 2, as you know, main care providers it's working with, and that is 2 commissioners, Portsmouth City Council and Hampshire County Council. Of course, they've got Solent and they've got Southern NHS Trust they're working with in various things as well as commissioners. But the two councils, City Council and Hampshire County Council, and our discharge times in Portsmouth, compared to those of the neighbouring county council, our discharge times are far, far better. And QA has issues around discharge with its with its statutory partners, but we are the better, if I can put it that way. With regards to the first intervention we ever carried out, the biggest intervention that included having members of staff involved in the 8-week process from Portsmouth Clinical Commissioning Group, and we did a whole intervention around our discharge team up at QA. And at the end of it, we went through redesign, check, and then redesign through the Vanguard method, and we came out with a much improved process of getting people discharged from hospital and getting them back into their homes or into a supported living or a care home with the package that they needed in a much more seamless process. To do that, we really needed the support of the hospital's discharge team as well. And it really did completely turn on its head the way the discharges were done. The hospital allowed us to do that for 6 weeks, and our discharge numbers sped up incredibly. So the delays went right down. At the end of that process, the hospital decided, because they were working on that method with us and the old method with Hampshire, it didn't work for their management team. So when I met with the QA chief executive last week, Mark Cubban, I did raise this with him as the new chief executive and said to him, look, we have a way of speeding up discharge from hospital. It would be great if you can have a look at this in a lot more detail. And they've got a very good member of staff up there who manages all of their side of it. We've got a manager that manages our part, and Hampshire have got a team that manage their part. One of the things that Councillor Stubbs and I, with David Williams, our chief executive, spoke to Mark about last week, and I put it to him, if part of the delay and the confusion around things is about the fact that you've got a manager managing your lot, we've got something, then I'm happy for us to passport some of the management responsibility of our social workers working in the discharge team at QA to you on a service level agreement, done properly, so that you can speed up the process. We're looking into that. It's a project we're working on. That may well come in the next few weeks, because we are committed to making sure that people are out of hospital as soon as they possibly can be. Anyway, Dave, if you could maybe fill in some of the more detailed gaps that I've missed and answer Gerald's other questions as well. Thank you.
So to recap, the two key questions from yourself, Gerald, were about quality of service itself as opposed to the assessment process and the discharges from QA Hospital. Yeah?
Yeah,
Okay.
to begin with.
Absolutely, I'll anticipate more. So the first thing, in terms of quality of service, I think, as I said in my own introduction, we haven't intervened in the care market itself, and we haven't worked with care providers yet to do anything to change the way that care specifically is provided. However, what should happen, and what we're seeing happening on the ground, is that the assessment process itself, and most importantly the support planning process that falls back off the back of it, is far more personalised than it used to be, and thus the services that we're providing for clients are better suited to their needs. Because the system we had before was a 16-page assessment form that was highly prescriptive and very, very, you will fit into this box sort of approach, which meant that whatever needs clients had, there was kind of a standardised response to any given set of circumstances. In the new system, it's a much more fluid assessment process, and we've trained social workers to think much more about the individual circumstances and needs of that individual client, and then support plan off the back of that. So while the range of available services to us in the market is much unchanged at the moment, the way that those services are chosen by the social worker in conjunction with the client is much more personalised than it used to be. Does that make sense? The other thing off the back of that, and I've alluded to it in the report, is that we also do a lot more on customer feedback than we ever used to do. At the point where cases are closed, i.e. we've assessed, support plan, put in place a service, met a need and reviewed it. At the very end of that process, clients are asked, how was the service for you from the moment you phoned us to the moment we reviewed it, and specifically what could we have done to make that better, how could we change it? And then every single line of that feedback is passed to managers for review and informing their future planning. Does that make sense?
Could you also give the specific example about LD, from where the care packages were, how many days they were taking, to where it is now, because we've removed, 2/3 of the processes that we no longer needed to carry out?
I think we're perhaps talking about different areas here, because we haven't yet finished LD. We've finished on older persons and physical disabilities, but not LD. The
meeting that I was in, where I was given that we were, on average, a care package was, for LD, was taking, I think it was something like 280 odd days. We've now got it down to 40, is what, the meeting that you were sat in, I think, with me, with Mark, Angela, Mark Stables, Angela Dreyer, about 4 months ago. You may not have been in.
I wasn't
You weren't
in that meeting, so I
right?
can't
Okay.
comment,
Well,
I'm afraid.
right. Sorry, apologies. I thought you were there. I think that basically there was about 280 odd days on average it was taking to get an LD care package when it was referred in, and that was going back 4 odd years ago. That's now come down to, I think it was around 41 days on average, and really our target would be around 30. We'd like it to take about a 4-week period. So that is a really demonstrable, example of how the service for the individual has really improved by, taking out processes that we just didn't need to do, and speeding up, and also empowering particular managers within the process to make the decisions they need to make without double checking, triple checking, which, in this day and age, we just can't afford to do anymore, and we need to spend that money on the people and not on, members of staff sitting in the civic offices triple checking each other's decisions. So if we're employing people to do a job, we should trust them to do it and empower them to make the decision as quickly as we possibly can. And that's one of the things that did very much change through that. Apologies, Dave, I hadn't realised you weren't in that particular check presentation.
So the second question you asked, Joe, was about QA hospitals. So there's, in terms of the council's role in discharge from hospital, there's 2 key aspects to it. And I guess, I'm going to say again that we've probably fixed one half and not the other. So there's the availability of social workers to go onto the wards and assess patients in the hospital that may need social care upon discharge. We have radically redesigned that process and made it more effective. There are challenges, as Donna alluded to, in terms of integrating with other services, because from QA's perspective, they've got any number of different partners at any given point that, depending on the individual patient, they may or may not need different combinations of them. But the process works better, and our figures are better than they were. Notwithstanding that, the key challenge remains that the care market is under severe pressure, and yes, I'm sure that our hospital colleagues would say they find difficulty getting clients out of hospital because of pressure in that market. So as I alluded to in my introduction, that's, for us, the next key area that we need to focus on is strengthening and improving that market.
Thanks. That's really helpful, though. So if I'm right, what you're saying is that the bit at the front, the first bit, doing the assessment, has, because of the intervention, it takes less time.
Correct.
What we haven't done is anything about what people then get as a service, and that's the bit I think that's interesting. So whether the domiciliary care package is different or better in terms of residential care or nursing care, what people get, and is that better? So I think the thing that will define for me how successful this has been is when residents get a service, what service they get, when they get it, and the quality of that, and that would be really interesting to know. And I think the first area would be interesting to have a report in the spring. Is we know every winter there's winter pressures. It happens every year, and that impacts both on social care and on the hospital. I think it would be very interesting to have a report to look in the spring about how the joint services between the City Council and the hospital have worked over that period. I'm worried that if Donna is right saying that the hospital don't like this system and are not working with it, what effect there's going to be about that, and whether we need to spend more time working with the hospital. But so I think that is an interesting report to see if this is going to make a real difference to real people's lives in the service they get, how quickly they get it, and the quality of service they get. I've come back to learning disabilities in a bit, but that would be, can we have a report that looks at that in the spring?
Can I respond to that briefly?
Yeah, and then I'm going to answer.
In terms of the quality of service, I think I would agree that the range of services available in the market is unchanged, but it's important not to underestimate the impact that we can have by making better choices and more personalised choices for clients. So the feedback that we get from clients is generally very good in terms of the quality of the service they receive and how well it met their needs. Yes, definitely, the market needs to be improved so that when a social worker is meeting a client and they're talking about how to plan the support that client needs, that there's a wider range of options available. But we have genuinely empowered and enabled social workers to make a far wider range of choices than they were able to in the past, where it was very constrained around it. You know, you tick boxes around what needs there are, that generates a kind of arbitrary budget figure that they then have to work within. Whereas now they're using frameworks and principles to say, okay, what's necessary to happen here, and what's the best way of doing that. So I think, you know, the service has got better from that perspective in that we're using the resources in the market better. The market is largely unchanged. The other point there was around you know, working with QA. Any approach you adopt to service improvement that isn't the same as your partners, that will generate potentially tricky situations where you work in different ways. We've worked constructively with our colleagues up at the hospital. I was up there just last week meeting a team of consultants that the hospital had brought in, and there was a lot of common ground on addressing some of those problems. So I'm sure if the leader and council staffs want the report back in the spring, we'd be happy to bring on.
Well, I'm not going to preempt Councillor Stubbs. That's a request to make to him, and I can pass that on your behalf, Gerald, so that he can make that decision, and that may well be a report he was wanting to bring anyway. But what I want to do in answering your first question about, you know, thank you for the update on the intervention work, but you're interested in hearing about how this has actually helped individuals in terms of the care they're receiving. That isn't the purpose of this report. And I'll draw your attention to item 2 on the paper, and it says, the purpose. As requested by the Cabinet Member for Health and Social Care, the purpose of this report is to provide an update on the performance of the assessment function for those recipients of adult social care. So this isn't about a judgment call or an assessment of the quality of the care they receive at the end of it. This is about Portsmouth City Council knowing it was taking too long for people to receive whatever that care package may be, good or bad. It was taking too long for them to start receiving care. And so we have addressed that, and this report is to explain how we've done that, that, you know, a third of the departments within adult social care have had an intervention or are subject to an ongoing. We want to do it throughout the whole of the council, and we've got interventions going on in from transport through to, you know, P2P, pay to pay systems in finance, and this is going on all over the place, so that we've got departments that are starting to really complement each other around IT and some of the other points that Dave has made. But this was about the assessment function. But inadvertently, that has then improved the service for individuals, because rather than waiting for, you know, 9 or 10 months for their care package, they're now getting it within a month and a half. And that is still not where we want it to be, but it's far, far better, and it's a drastic improvement. So today isn't about whether or not, you know, the care company that are coming in to give, you know, your parents, your grandparents help and support are good or not. This is about explaining how we have sped up the process. In addition to that, what we have done over the last 18 months, taken a very conscious decision to move those residents in the City of Portsmouth receiving care that are able to onto a direct payment system. And that means rather than their social worker saying you're entitled to 45 minutes a day of domiciliary care to help you bath, wash, get out of bed, etc., and make you dinners and make sure you're taking your medication, and we are going to instruct blah company to come and do that for you every single day. With the direct payment method, the social worker, after the process has been done, says, yes, I'm approving your care package, and now I'm going to be putting X money onto your payment card, and you can employ the care agency that you want. So if that means you want to use ABC Care in Fratton, or you want to use DEF Care in Cosham, it's up to you. And if you're not happy with ABC Care, you can change who you want. It's not the council being prescriptive and saying, you must use this company. It's for the individual and their carers and their supporters, family members, to decide what best fits that individual. And one size doesn't fit all. So, as Dave has said, in a commitment to improving people's access of choice, we are moving to that direct payment method where we possibly can, because it really does improve the outcomes from what we've seen for people. And it certainly also, therefore, then reduces our bureaucratic cost in the civic offices, meaning we can give somebody a 45-minute care package rather than a 30-minute care package, because we are allowing them to use some of that money to pay for care, as opposed to employing someone in the civic offices to go through the accounting process of checking the care agency is invoiced properly, you know, for the care that we have instructed. We don't want to instruct anymore. We want individuals to instruct. Right. Any other questions or comments on this report before we move on to public health report? Gerald.
Thanks. I'm really pleased to hear that the Council is continuing the policy of direct payments. It's been a national policy and a Council policy, I think, for at least 10 years, if not 12 years. And it's really good to see here that the Council is interested in carrying that on, because, as you say, it empowers people, and it's been a very good national thing for at least 10 years. So that's really positive that that's continuing. I think there are lots of other questions about this, Dave, and it'd be really interesting to see how the intervention works and makes an effect on real people's services. Can we come back to the learning disabilities bit? Because one of the things people were talking about, I think you talked about, David, was the way in which this allowed packages of care to be personalised and tailored to meet the needs of particular people using the service. Now, the feedback I've had from people with parents of people with learning disabilities is that changes in learning disabilities have done the exact opposite. That where they used to have choice, that choice has been taken away from them by the council. Because in day services, they're now directed geographically to which services they're going to get, and so all the choice has been removed. Can you update us in terms of the meetings you've had with carers and parents of people with learning disabilities to look at that issue, and how the intervention you're doing can reverse the lack of choice that those families have been given because of the decisions of the City Council?
Okay, questions come through me as the chair. That's not the point of this report. This report is about assessing the processes that the intervention Vanguard system has addressed over the last 18 months. This is an update for the public and for members of the City Council around the Vanguard method of assessment. It is not about addressing or commenting on the care packages that are therefore delivered at the end of it, be that a daycare provision. That is not what Dave's job is. He is not somebody who manages daycare provisions. He is not somebody who is putting people's care packages and awarding them. He is not a social worker. This is a report to address the processes of giving people care packages and Vanguard. It is not about Dave to comment. Dave, you know, if you want to add a comment to that question, you can, but I would be mindful of what we are here and what the item on the agenda is today. And I think Gerald's question probably needs to be addressed through a subsequent report back to this portfolio meeting, because we haven't got any information and we'd be making supposition, which I think would be dangerous to do.
The report is about how the assessments take place.
Yes.
And as David has said, it's about trying to make sure that those assessments are personalised and meet that particular need and give more choice. Now, in the assessments that we're doing for daycare, for people with learning disabilities, the council is doing the exact opposite. We are taking away choice and we're taking away the personalisation of it. So how that this is about the assessment of people receiving a service from social services, and I think it is an entirely valid question to ask if what we're saying is the aim of this is the exact opposite to what we're doing. What is going wrong?
Well, I've had feedback absolutely contradicting what you've said. I've had excellent feedback from people about the improved time of care package delivery because of interventions, because of what we've carried out throughout adult social care. We've had very, very good feedback about people in terms of care agencies saying that it's much more straightforward and simple to work with them now. We've had great feedback from the social workers themselves. We've had great feedback from carers. We've had great feedback about the direct payment system, about giving people the option to decide. So actually, actually, you know, whilst you've given one take on it, I've got several examples I could give you, very good, strong examples, and up-to-date recent ones that actually contradict that absolutely entirely. Dave, would you like to comment?
Just briefly, if I may, purely in terms of my suitability to answer Gerald's question, the scope of the work that I've led is set out at 3.2. I was briefly involved in some work with learning disabilities towards the end of 2016, but since the start of 2017, the work's been in the hands of the service management. So if we needed an update on that area, I'm probably not the person to give it. I'm sorry about that.
Right.
So can I ask through you, Dave? You said you were in the process of doing work on learning disability.
I was briefly involved in some work with learning disabilities in the autumn and winter of 2016.
But the Vanguard method is not being used in adult social care on learning disabilities, or is somebody else in the Vanguard team
Yes,
doing
he's just not
that
the lead
work?
interventionist on it. There's another interventionist who's leading on it. I thought Dave was. I got confused. We've
Fine.
got about 12 people across the council who are, we've got 2 or 3, actually probably 2 at Dave's level that are very senior interventionists, and then we've got people underneath them that are also lead interventionists, but not as experienced as Dave is. And actually it's one of our, it's a different interventionist that was leading on that one. I've been in several feedback, check presentation and redesign sessions around social care departments over the last 18 months. I got confused. I thought it was Dave. It's not. So apologies that I asked him to comment on the detail of the assessment reduction from LD, because you wouldn't know about that because you weren't the lead interventionist. So yes, that's
In which case,
someone
Dave,
else.
could you ask whoever is doing that work to let me know which groups of carers and parents they have met as part of this check phase?
And I think a lot of it was driven by the social workers, and it was about processing and assessing our processes in PCC to understand how we could take out some of the risk that we had built in as a council. So with the Vanguard method, it works very, very well where you have a process-driven system. And I think because of that, a lot of the communication there was around with social workers and the different processes and finance and other people in the organisation who had to tick bits off before the care package was delivered. That was a key part of it. Right, okay. Any other key points around this before we formally note the report? That's all we're here to do today, is to note the process of intervention throughout adult social care over the last, since the autumn of 2015. Anything else to note or comment on this one before we move on to the Public Health Annual Report? Okay, thank you much for coming along. So item 4, the Adult Social Care Measures Update is duly noted and will now become public record. Thank you very much. Item 3, the Public Health Annual Report, and we've got Jason, our Director of Public Health, here to introduce the report. So over to you, Jason. Thank you.
Thanks. I'd like to introduce this report with the first point being that it's very important to stress that this is an independent report of the Director of Public Health on the challenges facing the city. It's not the report or the opinion of the administration or opposition or any of the politicians, and where possible the report tries to be politically neutral, but inevitably where policies may impact on health either adversely or miss opportunities to improve it, I have a duty to highlight this. I think historically these reports have tended to be very long and detailed, looking at a lot of things that we refer to broadly as the wider determinants of health, concepts like employment, the educational opportunities people gain in the city, their access to a range of services and things that will impact on their health, but also thinking about the lifestyle factors, so-called lifestyle factors of smoking, obesity, how much people drink and their impact on health in the city. All of those things tend to be very closely related to deprivation, as people will know, and so the reports historically have tended to be a lot of maps that tend to mimic the map of deprivation in Portsmouth. So we've tried to move away from that this year to something that's a little bit quicker and easier to read with some key highlights in it, if you like. As a result of that, it loses some of its granularity, and apologies if that's an issue. We're going to try and make sure that we have the report being one thing and the Joint Strategic Needs Assessments being something else, so that the JSNA tends to have that more granular detail if we need it. The key themes, I guess, for me is we're trying to deliver population health improvements in a time where we've got less resource to do that with. And we have historically focused very heavily on those lifestyle factors, and we've focused on interventions that try to deliver a sort of face-to-face response to some of those lifestyle factors. For many of the things that we do in population health, the level of need out there in the population is so high that trying to address it face-to-face is a bit like trying to empty an ocean with a teaspoon, and we have to think about, in times where we don't have that same level of resource, how can we move away from that model where appropriate to try and choose a model where we're making sure that we have analysed the drivers behind a problem, and we're making sure that sensible policy, both at a local and national level, is being produced and implemented, so that we're trying to change the drivers rather than the outcome at the end, rather than the problem at the end, so that we improve outcomes over a whole population rather than just for the few people who can get their hands on the services. As ever, we've got a competing problem, I guess, and that's sort of highlighted on page 5, where some of the duties that we have in public health is around reducing inequalities mean that we have to inevitably focus on some very vulnerable people who have specific problems that make quite a big difference to their lives. And in particular, I think we have duties to make sure that we're looking after people who are using substances and alcohol in a way that's seriously damaging to their health and to the health and outcomes of their families. So inevitably, although we would like to move away from a model where we're just delivering a service, we still have some services that very much support people at the very vulnerable end of the spectrum. I think the problems that I see facing Portsmouth are not unique to any urban unitary in the country, and particularly to one in a more deprived area. We've highlighted in this report problems around smoking and tobacco use generally, around a rise in drug-related deaths, and concern around the increasing use of illicit substances. Possibly not an increase across the whole population, but certainly an increase in the more damaging substance use, and particularly in heroin use in the country, but also in the city. And the real, I guess the question for us is, where can we address these things that will have the most benefit and impact? And for me, that again comes back to how can we address child poverty in the city, because really a lot of our problems get embedded at a very early age, and how can we work together with Children's Service to do that. There's a couple of other areas where I think those are the things that will help us with some of the really nasty pressing social problems that we face in Portsmouth, but we've got much broader issues, no pun intended, around a rise in obesity and physical inactivity that seems to be fairly relentless as a country, that we still haven't got to grips with as a nation. And really, for me, the one thing that we really need to do to try and address that is to build physical activity into people's daily routine. And for that, it's a focus on shifting the mode of transport that people use wherever possible to encourage walking and cycling. And anything that we can do to move that, I think is going to pay a dividend for us as a city. I'll leave it there and open up to questions, if that's all right.
Thank you very much. My comments with regards to this report, I did read it obviously last night in preparation of this meeting, and it's really interesting. I enjoy these ones. Obviously, they do come to the Health and Wellbeing Board as well, which is where I would normally see them. And, you know, it does take you actually in an interesting journey from starting off with the population numbers in the city, talking about stats around housing and fuel poverty and overcrowding, and then it talks you into birth and maternity services, teenage pregnancy, then it moves on to drug and alcohol, and actually children living in child poverty measures obviously as well. So I think I like the fact it's a reduced report. I think it's really, really good. As you say, it's your report on the snapshot of the city and where it was throughout the year of 2016. A couple of comments, I think, from my perspective. I've got one comment on behalf of Councillor Stubbs, who's asked me to say this, and probably won't be a surprise to you, Jason, which is on item 12, around the high strength cheap alcohol. You know, probably a conversation for you to have with him about how we take that one forward, but... Again, sorry? Yes, absolutely. He doesn't feel that the council's position is that we are going to be actively working towards reducing the places that it is sold legally. But, you know, I'll allow you to take that one up with him. But seriously, from my perspective, I was really pleased to see item 14 of this report, for example, the percentage of children receiving the 2 doses of the MMR vaccine, that actually the national average is 88.2% and in Portsmouth is 89.3%. So I'm pleased about that, because I'm sure that even 5 years ago we would have been below the national average. Thereabouts, do you think? Okay, but anyway, maybe marginally, I'm sure it wasn't much, but actually to be above that is good. There are several points in here that, of course, we have concerns with, that we all want to and we are addressing through policy going forward. But, for example, and something that I've been quite involved in over the last couple of months, the number of young people aged between the ages of 10 and 24 admitted to hospital as a result of self-harm per 1,000, the national average in England being 431, but in Portsmouth being 635. Now, what I think would be quite useful, that I'd really quite like to see actually, is how other urban areas, other cities, how they compare. So is it that the average for England is 431 because, of course, that takes into consideration children living in rural and semi-rural areas, which brings the average right down? Or, you know, if we compared ourselves to statutory neighbours such as cities, is 635 the average, or are we still above it? Now, that even if it is the average amongst cities, it's still not good. But
we're worse than our for comparator groups. So when we compare ourselves to other cities that have been recognised as roughly something a bit like Portsmouth, we've still got a higher rate of self-harm recorded at the hospital. And I guess that's a slight caveat, I guess, to any of these figures, is the way hospitals record things can change from place to place. So if they have a particularly good system for recording self-harm, we may be guilty of beating ourselves up for something that is possibly the same as other places. But regardless of that, I share your concerns around this area. We're bringing forward our suicide prevention plan, and we've tried to, a lot of places have separated out self-harm from suicide prevention. I'm trying to put them both together.
My understanding is the statistics, the statistics, as I understand it, are very, very close. That youngsters who self-harm are at significantly increased risk of suicide, and so there's a very strong statistical connection.
Yes, and another caveat, I guess. You're certainly very correct in saying that people who self-harm have a greatly increased risk of going on and taking their lives. What the problem is, I guess, for practitioners is that the majority of people who self-harm don't go on and take their own lives. So as ever with suicide, it is a mercifully rare event. And it's very difficult to pick one particular risk factor and say that addressing that one risk factor will solve a problem. Or even putting myself in the shoes of practitioners faced with somebody in front of them on any given day, to choose that one factor and say that's either protective enough for me not to be worried about their suicide risk, or scary enough for me to say that this person is at incredibly high risk. They have to treat each person that they see as being potentially at risk, because we don't have strong enough predictable risk factors to say you can ignore this person's potential risk of suicide. So I think that puts practitioners in a really difficult position, and we have to recognise the challenges that are faced by GPs and people in the hospital and our own social care services when faced with people whose risk of going on and ending their lives is there.
Two final comments from me before I then pass this over to Councillor Fenner-Jackson. You mentioned the obesity levels and the, I mean, we have got over 28,000 people in the city that are active on I'm assuming that's probably a weekly basis. So that's good, but when we've got a population of 213,000, it's not as good as it could be. But the national sugar tax, obviously, that's coming in next year, which the government are introducing, I'm hoping, from reading your report, will have a positive effect on maybe changing some behaviours and making people think a little bit more about some of those things. Let's wait and see if that's the case. But really, just having lived here all my life and obviously understanding the history of the city quite well, you know, it seems to me like Portsmouth, not so much sort of pre-war and in the sort of 20s and 30s when everyone was living really sort of around the dockyard and, you know, in Portsea and sort of parts of Southsea. And there were, you know, 250,000 people living in a very, very crammed in area. And the rest of the city, you know, Copner, Hillsey was farmland, we had an airport here and other things. But actually, as the city then developed through the 50s, the 60s, the 70s, the 80s, the 90s, I feel like Portsmouth almost became a tale of two cities. And, you know, and I take Elm Grove as the dividing line of the tale of two cities. You know, one side, the southern side of Elm Grove, you've got a very, very, you know, one of the most affluent parts of the city going down in towards around Palmerston Road and Kent Road and down towards Old Portsmouth. And then literally the northern side of Elm Grove, you know, away from Kent Road going the other direction, you've then got the absolute opposite in terms of deprivation. You've got one of the deepest parts of deprivation within the city in Somerstown and one of the most affluent parts the other side. And I think in a city as small as this, what's stark to me when I'm looking at some of these things is that, you know, roads, physical regeneration is key to breaking down deprivation and increasing life expectancy in the more deprived areas. You know, credit where credit's due. You know, the previous administration started a lot of the work in terms of the Somerstown Regeneration Project and the sort of 10-year plan that they had and the Somerstown Hub and spanning communities, sort of linking together. And I think that the current, something that's in the current National Planning Policy Framework, the NPPF, you know, that's been around for a number of years now, that states that any new medium or large-scale housing development must provide a percentage of social housing. In fact, it's been on local radio this morning here in Hampshire on BBC Radio Solent, talking about affordable housing and also talking about you know, developers' requirement to build affordable housing. It's only by doing that that we're able to really have a positive impact on people's long-term health and well-being, which actually, when you think about why a council exists in the first place, go right back to the start. We are here to help people live happier and more fulfilled and protected lives, and you know, and that's really a key thing. I think that the access to open space, you know, in certain parts of the city now, we are master planning from scratch. Things like Tipner, East and West, and also, you know, City Centre North. We've got an opportunity now to really invest in good urban green space in the middle of the city. Same as with Victoria Park, making sure that that largest park, right in the centre of a very densely populated city, we're using it better. People are wanting to go and relax there, enjoy seeing the, you know, the birds, the animals, the trees, whatever it is they want to do in green urban space, if, for example, they live in a high-rise block in the city. And I think finally the comment that you made around cycling and public transport and how that can help to improve lives. You know, I think every councillor on this council, you know, I hate talking for other people because you shouldn't do that, but I'm pretty sure that all of my colleagues, you know, feel the same way about improving cycling safety, getting more people cycling and using that as a tool not only to reduce pollution levels, carbon emission, and congestion, but actually to double whammy positive is also getting people, you know, healthier and, you know, getting people on their bikes is certainly, I think, a good thing. Anyway, I think it's a really good report. Thank you for bringing it to us. Very informative. I enjoyed reading it and I learned a couple of things in there as well last night. Gerald.
Likewise, I thought it was very useful and interesting. Just a couple of bits and pieces on it. On page 12, we look about air pollution, and people are becoming increasingly concerned about air pollution. And I thought the chart there was extremely interesting, because I think most people in the city would think that the thing that is most responsible for air pollution are cars, and it's not. So HGVs are the biggest contributor to air pollution. And I think the other one I thought was really interesting, so if you think about the number of cars in the city, at around 100,000. But if you look at shipping and think of the number of ships that use the harbour, it's a relatively low number, and yet they're producing half of the pollution of all the cars in the city are producing. And it strikes me that therefore that gives us two areas to work on to see if we can reduce. Because I absolutely agree that it's sensible to look at encourage people to use bikes, etc. But if there are ways in which the shipping coming in and out of the harbour are able to change their behaviours even slightly, because they're so few in number, the effect could be dramatic in reducing the amount of air pollution. And particularly thinking of our city, the harbour is on the west of the city and prevailing winds are west to east. So everything that's produced in the harbour is spread across the city. Yep. The other thing is to look at a strategy of what we can do with HGVs. Now, I don't know if it's the right thing to do, but I think at least we should ask the question, does the London scheme about encouraging low-emission HGVs work? If HGVs are the worst problem in the city, and this is the first time I've seen that, what strategy have we got to try to reduce the number of polluting HGVs? Because the new lorries are way less producers of pollution than the old ones. So it seems to me there's a strategy for that. I've got a couple of other things, but I think those are potential areas of where we could have significant change which could make a real difference to people's lives.
I couldn't agree more. I think it's a really valid point to have raised. I mean, it is quite stark, actually, when you look at that. Yeah. I've just looked at it again now. And I think that is something that, working maybe in conjunction with public health, we asked Transport to have quite a good look at. Yeah. I mean, I can give a bit of an update on some of these things, bearing in mind that this is a snapshot of 2016, so it's almost a year old, but of course you've got to wait for the data to come back from various bodies, hence why it's here now in November. But it'd be really interesting to see the data for 2017, because in March of last year, I think it was April of last year, a European Union regulation came into force that meant that all ferries coming into the city, because is this 15-16 data or is this 16 data for this particular one? 15-16 maybe, but anyway, what came in last year was that the carbon emissions that come out of the chimneys of the ferries now have to have either scrubbers on them to take out a lot of the harmful chemicals, or LPG. This is a bit strange. They were able to pump the bad waste that comes out of the chimneys down underneath into the seabed, which I think is bizarre, because that then pollutes the food chain with fishes. Nonetheless, so I know that Brittany, for example, our biggest customer at the Portsmouth International Port, have put scrubbers on, and it costs millions of pounds. They put scrubbers on their chimneys. The new ferries that are being commissioned, as you said, are LNG, which Whitelink have just commissioned a new LNG ship. They're very, they've been quite excited and quite proud of making the point that it will be so much more carbon neutral and much better for the environment. So the fact that we've got the legislation there like that helps us. So it'll be interesting to see how the ferries part, the shipping part, how much it moves as a variant to this year. I was in America last week, as I know you were as well, Gerald, and in New York, where I was, the buses are so quiet. I couldn't believe, they come up behind you and you almost don't notice it. And the electric buses, and actually a number of cities across the country here that are actually using electric buses now, is certainly something I think we need to have a conversation through Transport with our. We are massive. We pay massive subsidies for bus provision in this city. We should use that to try and influence the kind of buses we've got on our streets. The HGVs, again, a really interesting one. a number of years ago, this is something that was actually done by your administration, Gerald. It was a great thing. When a lot of the HGVs were coming off the ferry port and they were trying to get to, for example, Airport Service Road, to the big industrial estates to offload their goods and whatever, they were coming up from the ferry port through Kingston Crescent, up North End High Street, so tight, so crammed, buses coming in the opposite direction, 20 or 30 gear changes for an HGV lorry driver just to get out of the ferry port, round the roundabout and up to, the end of the start of the London Road. Then up through Hilsey, then taking a right, going round the Coach and Horses, and then going up, which is virtually impossible to do an HGV, down over Norway Road, and then into the industrial estate. So they were going right through the main area where people are sleeping, living, walking, and the pollutants for North End and the people that lived along that area were horrendous. So we actually used powers available to us in terms of weight restriction for HGVs to mean that they had to come off the ferry port, go up the motorway, go up the motorway, go along go up to Cosham, come off at the Marriott, go along to the Hilton and come back down and go into the so you're removing the direct close access to the vast majority of houses and properties. I think that was undone at some point, but I need to review that to see where we're at, if we're still using that process or not, because those are the sorts of things that, whilst we can work with Parliament to try and legislate around HGV lorries, the clean ones, the dirty ones, etc., if we are able to control our road network, those sort of small changes are things that we can do to try and mitigate the impact of pollutants to people breathing when they're cycling, walking, etc. Jason, did you want to add something on this?
The questions around air quality are fantastic ones, I think, and thank you for those. I agree the impact of HGVs is marked, and we need to have a strategy that addresses all of those different areas. The real co-benefits to health come from getting people out of their cars, which is why I'm going to continue to plug that.
No, I don't disagree
but I totally agree with you around shipping and the HGVs. I think tale of two cities, I get Southampton as well. And we've got a very similar picture there, and the port's contributing roughly 10% of the air quality problems directly from shipping, but the HGVs coming into the port are contributing a lot more. And for me, again, I say I'm supposed to be not political, but still stand up for the people of Portsmouth and the people of Southampton. And in that respect, I was somewhat disappointed when the central government's air quality strategy was released, in that it handed a lot of the responsibility back to local authorities for areas where we probably need a combined approach nationally, because the risk, I guess, for a city like Portsmouth or Southampton in introducing a congestion charge or something else around HGVs would be that business goes to another port. And so we're inevitably going to be having to balance that up against what approach do we want to take. And it would be much more helpful if we had a central steer that said everybody should do this and this is how you do it. Similarly, for shipping, you're right, ships can do a lot to change their contribution. One of the big problems for Southampton, probably more than here, is a very large, small island of people, a small city arriving off your coast, comes along with 5,000 people on board who are going to live there for the next 2 or 3 days off the coast, and they don't have access to the mains electricity supply, so they run off a diesel generator for the next 3 or 4 days, and inevitably that pollutes the air across the city. There are potential solutions to that, but to convince the shipping companies to adopt some of those will require, again, a coordinated approach, because those are movable businesses.
But it shouldn't help us trying to persuade government to do stuff and look at this. I'm conscious of the time, both can I just two more quick ones? Page 24, number 20, the cancer screening thing. I'm pleased that we seem to be above average in terms of breast cancer, but we are below both for bowel cancer and cervical cancer, getting people to go and have their checks. I don't know if there's any work that we could do along with the CCG and with the hospital about proactively phoning people to get them to go to the... instead of just relying on paperwork, because I've got stuff and I get a letter which I respond to. One of the things we know is that literacy rates in the city are not great. And maybe we need to think of a different strategy to get more people there. Because if people can be screened for these things that are highly damaging, kill people, but you just don't notice, we could make a real difference. And I wonder if there's any additional work that could happen in the city to try to get people to come. Can I just? That's one. Don, I was very worried by what you said in terms of Luke and high strength cheap alcohol, because it's been the policy of the City Council for many years through licensing to try to make sure that we stop people being able to buy the very strong and very cheap alcohol that is so damaging to people's health. Now, I think that's been fairly successful, and I've sat on several licensing hearings where we've successfully got them to adopt an approach of not to selling this. Do I get the impression from what you said that Luke as portfolio holder is not on the same page here? Because I think that would be a worry.
He doesn't want to denigrate anything from the existing policies with licensing, what they're doing. I don't think it's about him trying to unpick anything that's been done, any good work. I just don't think he wants us to be too militant in terms of taking away people's choices and rights. So where we are at the moment, I think, is a sensible position. So I don't think he's got any issue with where licensing currently is. You know, ultimately, this is Jason's report that he's brought his opinion on public health.
Yeah.
But, you know, he did, when he texted me this morning on the train on the way to London, there were a couple of things he mentioned: air pollution, HGVs, etc. was one of them, actually. So I'm pleased you raised that one, Gerald. And the other one was around, you know, we are looking towards removing options to buy very, very cheap alcohol. Not just cheap, but very cheap.
Yeah.
You know, I mean, he maybe wouldn't disagree with that part so much, but it's the access to cheaper. He enjoys a cheap beer, shall we say. But I don't think he necessarily wants everyone to be able to go out and buy loads of cheap alcohol pops. But there we go. I can't really put words in his mouth. Of course, you'd have to take that with him. The point around the council thing is an interesting one. And I mean, obviously, we can't take on additional responsibilities that aren't our own. A lot of that is the CCG. But it'd be great as a suggestion to take forward to feed back to the CCG, maybe. Jason, what do you think?
It's even more complicated than that. This is one of those things that I don't think fared brilliantly in the NHS reorganisations. What happened is it used to be a CCG responsibility, PCT responsibility. It then moved to a centralised responsibility under NHS England, but with input and advice from Public Health England to do the commissioning and work around this. To be fair to them, with that complex brief and trying to deliver that in much bigger areas than a local authority area, they've tried to maintain the current screening programs whilst also introducing a lot more, and they've got the combination of vaccinations and immunisations as well as the screening programs to be commissioning on this. So at the same time as trying to work on these areas with relatively small resource, they've also introduced the flu vaccination at various ages for schools, so that all of the work that we're doing around trying to interrupt the transmission of flu in school children, who are the super spreaders, they've had to put all of that in place. They're trying to bring in more advanced changes in the bowel cancer screening and doing a lot of other work that's trying to go forward while still maintaining status quo and trying to improve other things. So I think inevitably they've got a very difficult brief in their defence.
I wasn't attacking you, just saying.
No. I certainly feel we can. The pattern we see in Portsmouth is not unusual for a deprived city, relatively, where we see good rates of immunisation but poor rates of cancer screening. There's a lot of factors, as you say: literacy rates, people's ability to actually get to things, and you know, when you haven't got necessarily access to a car, or you can't take time out of your job because your job's a bit more precarious than somebody else's, or a range of other factors can all contribute to poor screening rates. What I would say is that we do, at the end of the day, the screening, most of it is delivered through the GP practices and through their call and recall. And we do see quite a lot of variation between the GP practices. And the NHS England PHE combined commissioning team are looking at work to try and sort of address some of that variation between the GP practices so that we can say these are very good practices. What can the practices that aren't performing so well learn from them? And we're supporting that work. We're also trying to support better comms around vaccination and screening, because we've got access to comms pathways that PHE and NHSE may not have. So we're trying to join up our comms teams so that we can do more around that as well. And there's a couple of other things we're trying to do to help with that. But it is a very difficult brief, I think. I suspect the bowel cancer screening we'll see hopefully get quite a bit better because they're introducing a much less invasive approach to bowel cancer screening, and as that comes in, hopefully that'll pay a dividend.
It would be wrong of me not to highlight this, and I probably won't agree. I am concerned to look at the self-harming stuff, where it looks as if our rates are a third more than the national average, and again question whether it was a good idea for Off the Record to be shut down. It offered free confidential counselling to young people where they could just come in. That service hasn't been replicated. It isn't there now, and I think these figures say to me that was a really important service, and I think it's a great pity it's no longer there.
It is there, actually. In fact, I was speaking to a parent last Thursday whose child is accessing Off the Record, lives in Portsmouth. Off the Record are operating from an office and haven't, but most of it's done over the telephone anyway, and they do also have key workers. Off the Record is still operating, but obviously wasn't funded by this council, so where they choose to base themselves is up to them. Thank you very much, everyone, for coming along. Lots of good comments made today and observations made. So, thank you. And I hope that people who are watching it online have enjoyed the thorough discussion. And is it really necessary?
Yeah, really. I think it's really important that you and I are here as Conservative and Lib Dems, but the Labour Party and UKIP and the Independents haven't even appointed a spokesperson on this subject. It's hugely important. Do you think we should be able to talk to the other political groups in the council who've got councillors to try to make sure that they're represented here as well? What could be more important than getting health and social care right for people in the city?
It's a core, fundamental part of our business. I completely agree. Thank you very much all for attending. Thank you.